He's a known diabetic, non-insulin dependent diabetic, and he's had this ulcer of the big toe since the last 3 months. He had gone to a local surgeon. He was planning to amputate, but then uh, he was referred to us, and we clinically I felt that I couldn't feel any of the dorsalis pedis or the posterior tibial. Uh, Popliteal was a little dicey whether I could feel it or not. So we did an angio. I was anticipating there may be a SFA lesion also, but there is no SFA lesion. We've done the diagnostic angio, which we'll just show you now. And he has a tibial disease. There is a long segment posterior tibial artery occlusion, and the unfortunate part is that there is no decent posterior tibial in the foot. So we decided that there is no point in even attempting the posterior tibial. So we are going to now just tackle the anterior tibial and come out. So we'll just now, Nikhil is there. I'll tell you who's with me. Yeah, I'll just introduce. Nikhil is with me, working with us, and a partner. Then there is Shivani. Shivani is the anesthetist. She is our backbone. Patients, in case they are a little uncooperative, we are doing giving some sedation or maybe an analgesic during the procedure. Now, Nikhil will just show you the angio. Just show me the aorta, please. Why connect? Okay, this is the aortogram. Can you see the aortogram?
Yes, Girish, it's nicely seen here. And
okay, so there is nothing in the aortogram. We did the common femoral, right common femoral. That's okay. SFA looks okay. Profunda looks okay. And the distal SFA is also fine. Popliteal looks also okay.
yes,
Now I'll show you the below the knee. You are seeing the anterior tibial, which is showing multiple stenotic lesions. Peroneal up to now looks okay. Just go forward. No, show that same run. Y connector. See, now here you are seeing the posterior tibial seems okay.
yes.
You agree, Vimal?
Yes, all three vessels, except the anterior tibial there shows stenotic lesion.
Next, please. Now here you are seeing predominant runoff is from the peroneal.
Yes.
Multiple stenotic and occlusive lesions in the lower third of the anterior tibial.
Yes.
Posterior tibial is occluded in the mid calf.
Yes.
You are not seeing any reformation distally.
Right.
And if you see the foot now,
I think in this imaging, I think looking at the distal runoff vessels is absolutely important, and you need to look at the foot.
see here, Vimal, the
Yes.
posterior tibial, you are not seeing any decent, apart from one twiggly branch in the sole of the foot.
Right.
You are not seeing anything significant.
And the peroneal is
So,
the only
what would
part.
be your approach? Yeah.
This
What
being
do you-
a-
what do you
need
think
to,
would be?
in the audience, how do you look at it? And how many
Why
of you look
connector
at
the-
interventions here? Yeah, I see one hand. I hope some more hands. I'll put both my hands. But yeah, you are also there.
Your approach, you've gone across over,
Yes.
across the bifurcation.
Yes.
Would you not have been considering direct femoral puncture,
Yes.
minimizing contrast?
Yes, Girish. There's a question here. Would you do a direct?
Yeah, I heard it.
antegrade
I heard it.
puncture?
See, there are two schools of thought. There are people who would prefer to do an antegrade femoral puncture, ipsilateral antegrade femoral puncture, and do the procedure. I am of a different school of thought. I prefer not to do it. Because one, I have got to see the entire circulation of the foot, which I have not seen apart from a Doppler report. So instead of doing and done the angio, that is one. Secondly, the post procedure, I am more comfortable not compressing the same side that I have done a plasty for. And also the complication rates of antegrade puncture are higher. So these three factors make me think of not doing antegrade puncture. But yes, I accept the point that antegrade puncture is an option
Yes.
in these
Less
circumstances.
contrast, extra maneuverability, you can pressure, good little pressure more. Now, Girish, the
No, no, if you are so worried about, if you are so,
yeah, Girish. Yeah, Girish.
yeah, the if you are so concerned about the contrast, you have the crossover sheets which go all the way up to the popliteal. So actually speaking, you will have lesser contrast if you can use those crossover sheets which go right up to the popliteal artery.
Bifurcation, yeah. Girish, the idea now here is a great toe disease, and from angiosome concept, we would think this is more of a PTA territory. So, do you believe in angiosome concept,
Yeah.
or what is your idea here?
Oh, very much so.
Yeah. So,
Very much so.
so basically, angiosome is a target vessel that we look at, and we know that foot. We divide them into various zones where it is more supplied by the anterior tibial,
Repeat.
posterior tibial, peroneal.
Repeat,
And grade 2
Rona.
being more supplied by the posterior tibial, that should be your target. But here in this case, distal PTA is not existing. In the foot also, you do not have the plantar branches coming in. So you don't have anything. You are seeing good peroneal, good anterior tibial, which is forming the arch, and you anticipate there will be good flow. Once you open the anterior tibial, there will be enough flow to take care of local amputation if it is done for the great toe. So I think Girish has targeted his vessel well. The challenge is some stenotic lesions and a long segment occlusive disease, but looks quite amenable. I think so. Girish, what are your catheters and wires and gadgetry that you're going to use here?
See, what I've done is I've started with a crossover sheet, 6 French crossover sheet from the left groin,
Yes.
gone across and gone into the common femoral on the right side. Through that, I've taken a headhunter catheter, and after taking the headhunter catheter, I've gone up to the popliteal, and I am now in the process of trying to cross the lesion.
Yes. Now what catheter and wire
So,
is this, Girish? I can
can
see something
you
going down.
This, yeah, now what I've done is I've just taken a headhunter. I've not, as of now, used a micro catheter. Wire itself, then I am saving that much for the patient.
Right. So this is which wire? It's nicely
So
going down.
under roadmap, if you see, I under roadmap guidance, I am
I
trying
hope
to
the
go
audience is
across,
appreciating the wire has
and
gone down more or
I
less 90%.
think
You've probably entered the segment.
I think I am across.
So,
Yeah.
and this was which wire, Girish? Was it?
I've used a command wire that
Okay.
is from Abbott.
Okay, so command wire. This is supposed to be
So now I'm going.
a little CTO wire, or what is it?
Yeah, it can be used as a CTO wire,
Okay.
but yes, I would not since it has this pretty sharp tip.
Yes.
I won't call it a CTO, true CTO wire, but it is a hydrophilic wire. So
Okay.
I would be a little wary of using it just as a routine workhorse wire.
Okay.
But I knew that there is quite a bit of calcium,
Yes.
so that is why I think that I can place, keep it down up to here,
Yes.
and now proceed with the plasty.
I think there
What
is
do
a
you think?
question, how did you manipulate this wire, and it has gone down wonderful. I mean, congratulations to you and the team that we can see that it has gone down deeply. Any questions here from the audience? If you have, please, you can put it up. So this manipulation of the wire, since it was stenotic occlusive lesion, he has used a hydrophilic wire. Normally if it was a CTO, hard calcified, we would use some of these weighted wires, some coronary wires, all O14 with a support catheter and a support micro catheter. Normally as a micro catheter we would use pro-grade micro catheter, get down at the site and then manipulate the wire. And the usual maneuver that we do here is either rotational. You rotate the wire and try and find the central lumen of the artery. Often in an occluded segment we don't know whether it is a subintimal or whether it is through the lumen, but we try and manipulate that.
150.
But if it's a stenotic lesion, then we often use a hydrophilic wire here. So now we have got down into the tibials. Now what's the next plan, Girish?
Now I think we'll straight away go in and do the plasty of the anterior tibial.
Yes. And your choice of balloon, see, we are seeing this long segment and you will have 0.5. So do you use a tapered balloon or do you?
So right now I'm going to target, no, right now I think I'll be a little conservative.
Yes.
And I will use a 2.5 balloon only.
Yes.
And because sizing the balloon on the basis of the distal artery, and I think that looks like a 2.5 artery to me.
Okay, okay. And any specific length that you prefer?
Now, I would like to cover the entire lesion with the balloon.
Yes.
I don't want to leave it halfway. And from what I see, it looks like 150 millimeters, that is about 15 centimeter length.
Right.
So that is why I've taken 2.5
Yes.
into 150.
Great. So the idea here was that he wants to use only one balloon rather than take a short balloon and kind of jump it up. If the one balloon goes down, then he would like to use one balloon. If it doesn't go down, then he may take a short balloon to reduce the resistance and then do the procedure. But
Unlock.
if it goes, he will try and push it,
Side to side
push the
column.
balloon there.
Side to side column.
Vimal,
Bus.
is this a 018
Unlock.
or 014 system? Sorry? Is this a 018
No,
or
014.
system?
It's a 014.
Yeah, it's a 014.
It's
balloon
a
is this, Girish?
it's a command wire.
Yes.
Pardon?
Which balloon is this?
This is I have taken a coyote balloon. That
Yes.
is no coyote. 2.5 into 150.
2.5. Coyote is from Boston Scientific, so he's using that. Again, a good
Yeah.
014 compatible balloons. The sometimes there is
Now
a
I'm just
problem
advancing
at the
the-
trifurcation as you're doing it. You try to push your balloon does not go, and the wire starts buckling at the trifurcation, and in this case it will tend to enter into the tibioperoneal trunk. So you need to have a good support, good push and good pull on the wire to support and make. You can see that the catheter balloon has gone down. You can see the marker there down near the ankle joint in the calcified segment, and you will see how much resistance there is when he's inflating the balloon there.
The
The patient is really quiet and silent, Girish. This probably Shivani has done a
Yeah.
good job.
yeah. Yes. Give me one mag.
So he's going to now balloon inflate and we'll show
Unlock.
you on the DSA.
Tube down, table up. Okay. Now I get the entire length of the balloon here.
Yes.
So can I go ahead and balloon dilate, Vimal?
Yeah, please. You're all anxious here, yeah. You can see those narrowed segment as Girish predicted it at multiple levels, and there you can see that the whole balloon. Girish, what is the pressure now up there? Now you can see him moving the leg.
Halunaka, it's on 120. Sorry, 12 atmospheres.
12 atmospheres.
This balloon can go up to 14 atmospheres.
Yes. And your plan is to keep it inflated for how long now?
For 2 minutes.
For 2 minutes, yeah. So we normally go at a higher pressure. These are all calcified lesions, and we maintain a pressure for nearly 2 minutes to get a little prolonged dilatation. After that, we'll get the balloon out, track it up, and dilate the whole segment, and then see what is happening. If there are any dissections or any recoils that need to be reattended, we will do that, maybe at a higher pressure or a higher diameter balloons, if that is what is needed there. But yeah, this looks that the balloon has opened up very well, and we don't see really any kind of stenotic segments visible on the balloon at all.
Yeah.
So yeah, good 2 minutes is the
Residual
time
waste.
that we need to give for this kind of dilatation. Any practice,
Yeah.
change of practice, or you've been doing it, or any different that you do that we can learn? So you are doing some peripheral interventions, yeah? So anything different that you do, or you want to suggest something? Mic there for him, please. How many of you are interested in starting a peripheral interventional practice? That is equally important question.
I am an interventional cardiologist, but we started also peripheral intervention 25 years ago. We because of our training with coronary devices, we started to use coronary balloons and coronary stents for peripheral before they developed this new long balloon, you know.
Yes.
This is the same technique than for coronaries, you know, exactly the
Right.
same, you know.
Yes. Yeah, so yeah, these long balloons have changed, the working, and it's made things easy. Otherwise, the same length, 4 centimeters, if you have to kind of, overlap the segment, this would take probably an hour more to do the whole procedure. So these long balloons have changed it, and
More than that,
doing
Vimal.
good. We have these taper balloons now, where there is 2.5 down and 3.5 on top, or something like that, so that you're not worried, you're over dilating somewhere or under dilating else. So these tapered balloons are also something which has made things easy. So yeah. Now I think deflated, the balloon is deflated. This patient, if you saw, he moved.
Vimal,
Yes? Yep. Girish?
Vimal, the other thing apart from what has changed the whole thing, why we take the long balloons,
Yes.
is basically because when you have a stenosis, and if you balloon dilate that stenosis halfway across the lesion,
Yes.
you tend to fracture the plaque,
Yes.
and the possibility of dissection is higher.
Right. I agree. I go by that. Yes.
So there are
So the whole idea
halunaka.
is you want to cover the whole length.
So
with the
that is
balloon.
why we prefer.
So you do not have these dissections there in between. Yes. There it is, another segment which he is opening up. Again the same 2 minutes dilatation there at a high pressure, and I was-
Timer reset.
the patient moved his leg primarily because there was some amount of pain, and that would happen if it's a hard calcified lesion and there is some amount of dissection, or you've gone subintimal. As I said, in no case you can guarantee and say that you have always been through the lumen. There could be a passage of wire which was subintimal, but this pain is because of the stretching of the artery, and the perivascular neural tissue gets stimulated, and that causes this pain. So yep, so that is what the plan is now. And Girish, how often do you end up putting stents in the tibial vessels?
Out of maybe 5%, max 10%.
Okay. And then what is the choice of stent that we have for the
But
for the tibials?
We always use a drug-eluting stent in
Yes.
in the tibials.
So these would be the spot
One
stent.
of these newer drug-coated.
So often we use the stents again very rarely, and we end up using the coronary drug eluting stents here. Usually spot stenting, even if the lesion is 18 centimeters. If I find a localized segment recoiling or dissected, and there is a flow limiting dissection, then I would put a stent there. Otherwise, we don't put stents here. The whole idea is that once the vessel is open, if it remains open for 2 to 3 months, the wound would heal, and the artery may reocclude, we need to prevent re-injury, and foot care and footwear becomes a very important management following the plasty in these patients. What has been your protocol as far as antiplatelets is concerned?
You're asking me?
Yeah, Girish.
Normally, we have at least for 3 to 4 days before the procedure, we give dual antiplatelets.
Yes. And then after
If we suspect that there is any thrombus or whatever, then we may add low molecular weight heparin. Otherwise, most of the time we just put the patient on dual antiplatelets. And of course, after the procedure, minimum 6 months, preferably 1 year, we keep the patient on antiplatelets. But invariably, these patients may or may not have what you call ischemic heart disease. So then anyway, he is going to be on the antiplatelets.
Yes.
So we just continue for a longer period of time.
Another challenge with these diabetic patients is the kidney issues, and invariably the creatinine is high, and therefore we need to kind of take care of that with so much of contrast going in. So any set protocol to do that to prevent CIN?
Yeah, if you always have a look at the creatinine, and if the creatinine is borderline, then you would start on all your renoprotective drugs like Mucomix and soda bicarb before the procedure, and continue the soda bicarb at least for 12 hours post procedure.
Right. So
N-acetylcysteine we normally start.
We've still not really got the real evidence, but we still continue to use that. We hydrate these patients and start them on soda bicarb 3 hours before the procedure and continue for 12 to 14 hours after the procedure, and obviously monitor the creatinine in these patients. So that is what now this is what is happening, Girish. You're going down again.
Vimal, if you saw,
Huh.
yeah, because there was a residual stenosis. I'm not sure whether I dilating that segment. If you see the last run, we'll just show you the last run again.
Yes.
See, there is a residual stenosis on top.
Yes.
I have a feeling we have not plastied that segment.
Perfect.
We missed out on that segment, so I'll just plasti that now.
Yes. So otherwise the results are looking good. How often do you have to do an antegrade tibial or a dorsalis pedis puncture in these kind of patients?
About 20 to 30% of the time, especially with the calcified lesions, if we cannot manage to pass the wire antegrade, then we are forced to do the retrograde puncture. We puncture the anterior tibial or posterior tibial, or sometimes even peroneal, just above the ankle, and then try and snare the wire from the percutaneous route, and then do the antegrade plasty.
Perfect. Yeah, so what he's trying to explain is if the stenotic segment cannot be crossed from the crossover sheath or from upper to downwards, then he would come from below upwards, and we puncture these tibial vessels down there in the foot or at the ankle and then come up in a retrograde manner. And often we find that if you've not come from above, from below when you go, the cap is little softer and it's easy to pass your wire. Once you've passed it, the rest of the manipulation is from the upper end. So you need to get this wire snared from the proximal approach. So we come into the SFA and then pick up this wire, pull it out, and again start the whole work from the opposite groin. So the tibial puncture is only a needle puncture often. You don't put any catheters or anything from there. You don't want a big hole there and then have a problem of closing that hole. So that is what we do quite often. And I'll try and show you one of the case like that which we did recently in one of the patients here. So yes, there we can see that the balloon is being inflated and the stenotic segment is being dilated there. Look at the calcification that is there. This calcium often is a good help also. Sometimes it is totally occluded, you don't see the vessel. The calcium tells you that this is the track on which you got to go, and that's where we start manipulating a wire, especially these CTO wires, and that helps us to track our wire across. So I often make use of this calcium.
Nicotinamide.
Sometimes even these calciums are useful for making an anti-grade puncture. That's your target and you can go through that. So yeah, a lot of new techniques and technology that are there for the peripheral work that we are doing. Girish, you've done atherectomy here for these kind of lesions?
Yeah, yeah, we've done atherectomy.
Right.
And the only problem is that if you are going to do an atherectomy, I don't think you can do a standalone atherectomy. It has to be followed with a drug-eluting balloon.
Okay.
That is what my this
Yeah, and then the cost
feeling
factor
is.
comes in.
Unlock. Correct, correct. So you first of all, the drug-eluting balloon is expensive, and so is the the atherectomy device.
Right. Yeah, so it's very occasionally that we do that in the tibial segment or anywhere. And nowadays, even for the tibials, we have these drug-coated balloons which are now available in the market. And we've been using it as and when we can, especially based on the affordability of the patient. Though we would like to use in many of our patients, but yeah, that restricts us somewhat. And any specific...
Okay, now, Vimal, I'll
yeah?
just take a check shoot now.
Yeah.
I'll just take a check shoot.
Yes. So looking good, I suppose all of you appreciate that probably, yes. The segment which looked little narrowed is now opened up well. So proximal segment is good.
तेरा पाय हलू नका हो.
This being a DSA, Girish is requesting the patient not to move the leg. Otherwise the images won't be good. I think one important thing that I would like to convey to my cardiology colleagues is for the tibial vessels, just don't do a conventional angiography. You need to do a DSA, otherwise you will not see these vessels, and especially in a calcified segment, obviously you will not see it. So this looks quite good. The flow is very good there. We'll go down further and look at the foot, which is what the target is. So you need to check the foot completely to confirm that your job support the posterior tibial territory, and therefore we need to have a good flow in the anterior tibial.
Nikhil holding the foot.
You can see that the flow is so delayed over here overall in these tibial vessels, and don't move.
Vimal,
sir.
I have done the plasty of that lower anterior tibial.
Yes.
There is still a little recoil,
Yes.
but I'm just wondering whether for
Inject
that
NTG
segment.
or something, or
Yeah.
would that be of any help?
No, I have
there?
done it already.
You have done that? Okay.
No,
So
no,
we
I just
normally,
did it.
After the
Yeah,
plasty,
this was the
we
shoot
put on
after-
an NTG shot, so that any kind of a spasm. But yeah, there is a tight narrowing there, which would definitely require attention and probably one more.
So, okay, we'll
dilatation
just
there.
give it one shot. Fluoro at your feet. So we'll give it one more shot
Yes,
and see. You can see there is quite a bit of calcium there.
that's right.
Okay, unlock please, table. So what we had done was last time we had gone with a pressure of 12.
Right,
We'll go up to around 14 now.
that's right. I think that's wise. Yeah, that's good. So again, 2 minutes dilatation there. And sometime if this does not help, then we may take a short balloon and maybe they go up to, this was 2.5, we may go up to 3 and see if that helps to dilate the vessel and keep that segment open. So one could do that as a next chance. But I think the whole purpose, I think time-wise, Sanjay, how are we? We are okay? Yeah, so I think meantime this is happening. If there are more questions which Girish can answer, we would like to do that. If anybody wants to ask. Yes, sir.
Increase the stenosis for these sort of long balloon segments.
Yes. So Girish, the question is, what is the rate of restenosis for such long calcified lesions?
See, there is no real study that has been done, but the idea is that is irrespective, in the sense that what is the aim of doing this is we are not trying to give him a pristine looking artery which will remain patent all his life. The idea is that he has a non-healing ulcer which has to heal. If we can manage to heal the wound, even if it re-stenoses or reoccludes, as long as they look after their feet, in the sense you have good foot care, these patients will not have ulcers. I can show you, if you see this patient's opposite side, I'm sure it is worse than this side, but he does not have an ulcer, so he doesn't have a problem. So important is that injury is the precipitating factor for non-healing ulcers. So though they may stenose, our main aim is to salvage the wound, in the sense heal the wound, and if we manage to heal the wound, we have achieved 100% success.
So I think, as said and done, the whole intention to treat is to salvage the foot or reduce the size of amputation. And if I have to look at the data in a tibial vessel, we have a salvage rate of about 72%. That is not a bad outcome there, though there is effort being done to see that if you can keep the artery open, so therefore drug-coated balloons have come, there are stents coming in, and now I'm looking at bioabsorbable stents which will come in. So a whole lot of things are happening in the tibial vessels, but the whole purpose is, or the intention to treat is to prevent amputation or reduce the amputation. So yeah, that is what the whole idea is. But yeah,
You
these
know,
arteries
Vimal,
will close.
there is an
Yeah.
there is a thing that is coming out where that is still under investigation. Basically, all your drug-coated balloons, they are basically coated with anti-mitotic. Is some amount of diffusion of that drug peripherally. They say that there may be a possibility. There's no data as yet, but
Yes.
there may be a possibility that the wound healing may be further hampered.
Yes.
So you have to look at that aspect also. I'm not saying that is correct, but
Yes.
that is another point of view which has to be kept in mind.
Yes. So yeah, there are quite a bit of pluses
You
and
agree with
minuses
it?
on every side. Yes. I think now we need to see that, whether that segment has come up, and try and see that whenever he is now making a contrast injection, he is withdrawing his catheter out of the artery. As such, it's a small artery. With your catheter in place, it further reduces the lumen and reduces the flow, and may give an apparent impression that the segment has not dilated.
Ugar.
So, except keeping the wire there, he now wants to do his angio.
Jara pay halu naka. Ready?
So that very close to the ankle was that narrowed segment, and now trying to see that, and this injection is being made somewhere in the, now that segment looks fairly good, and the flow is forward quite good.
Will
Yeah.
see if you remember, Vimal, if you see the pre-angio, I'll just show you the pre-angio.
Yes.
No, show me the directory. Go up,
Yes.
up, up. Show me number 7. Some number 7, previous. Now, if you see this, you are
Yes.
seeing predominant flow is from the peroneal,
Yes. Yes.
right?
Yes.
The anterior tibial is coming much later.
That's right.
Now, if you see this shoot,
Yes.
go minus, minus. Now see this shoot.
Yes.
Both of them are, sorry, minus, minus. Now see this shoot. No, minus again. Yeah. Are
Yeah. Go to the last image,
khalsa,
Girish.
khalsa.
Yeah.
Yeah.
So
No.
basically, he wants
If
to
you see
the
this,
flow
now you're seeing both of them are coming together.
Yes. Yes. So that itself means that the anterior.
So
tibial
that
has now
suggests
been
that
opened
you
up,
have definitely, yeah.
yes,
correct.
the flow has improved there.
And I'll show you the final image.
Yes.
Minus. This is the final shoot of the foot.
Yes.
You don't see any maybe 10% stenosis there,
Yes.
but I'll accept it. I
Yes.
don't want to.
Right. I think so.
So, would you think this would be an acceptable
I
result?
would take it that
and
way.
we call it quits here?
Yeah, I would quit from here. You know, it's always said that the enemy of good is better. Trying to do this, you throw in an embolus there and block off the only existing dorsalis pedis and the branches there. You would lose everything. But yeah, this is acceptable. And if you want to just take a picture with the wire out, just a little higher up images and demonstrate again.
Okay.
If contrast is okay,
Okay.
with you. Patient's
Unlock.
create is okay.
Just
Little higher
yeah.
up, That's
Remove the mag. No, 1 minute. Demag, unlock. This much is okay?
Yeah, I think so.
जरा पाय हलू नका.
This is the. Yes. I hope all of you can appreciate this now. The flow in the anterior tibial actually is a little more faster than the peroneal, and the peroneal is well maintained, the collaterals are maintained. Posterior division branch of the peroneal is supplying the heel and the segment, and the anterior tibial is looking after the foot, and we
Hidden
hope that there
terrain.
is adequate supply to the great toe. And often after the procedure, we would do an handheld Doppler to confirm whether that pulsation is good and demonstrate that. We do not really look at TCPO2, but ideally, yes, if you want to really see the wound is healing or not, TCPO2 is
And terrible.
something that one can do. It's little expensive and not all the institutes have it, and therefore we use it limited. But these are some of the things. Now, obviously, Girish, you're withdrawing everything back?
Yeah, but that's why I just want to. Well, you have to be a little careful with this crossover sheath.
Yes.
So we don't just pull it out
Yes.
from the contralateral artery.
Yes.
What we do is we just always put in a catheter with a termo,
Yes.
and that's what I'm demonstrating.
Yeah, you can have a backlash kind of a thing as you're just withdrawing.
See,
it.
this is your crossover sheath.
Yes.
Sorry, this is your crossover sheath. You have got a termo across. I put the head hunter catheter, and now I will withdraw this sheath. Show me on top.
The only problem
So
with,
that there is no whiplash.
Yes. Yes. So that's great, Girish. Really wonderful demonstration of a good case of a tibial artery angioplasty successfully done. And you have question, yeah.
Just one basic question regarding, for example, complication like dissections or advanced case perforation.
Yes.
What will be the approach in this case, like cover a
Girish-
stent or something like this? Or
See,
Wha-
it all depends on what level it is. If it is a flow limiting dissection, then and then only will I stent it. And usually I refrain from stenting anywhere below the mid calf. I would always stent maybe proximal arteries, that means in the upper calf, but I will not like to put in a drug-eluting stent in the mid calf downwards. That
Girish,
is
two
one,
more-
and
two
that
more- yeah.
only if there is a flow limiting.
Two more complications
Yeah.
that one should be aware of, and which could be a disaster, which I often say thrombus is the biggest enemy for any vascular specialist. So
Oh, yes.
if there is a thrombosis
Oh,
or
yes.
if there is a plaque which get dislodged and goes downstream, then what is your approach, Girish, in these patients?
See, that is most important, that though we give minimum of 5,000 units of heparin when we are starting the angioplasty.
Yes.
Secondly, I always now, thanks to you, always have an infusion running from the side arm of the sheath. If you can see here, I don't know if you can see it, I'll just show you. 1 second. Can you focus the camera here? Where? Okay, I just focus the camera. Okay, I'll show you. I've got a side arm. This is the crossover sheath, and I've got a pressure infusion.
Yeah, constantly flowing down there to see that there is no thrombus. Otherwise, exchanges, some leakages, whatever, we would find that
Yeah.
the crossover sheath would get thrombosed, and you will actually push it downstream. So we have this pressure which runs down the side arm. So that is one more precaution. So heparin and pressure. And Girish, if there is actually a
one other thing
thrombosis,
is that we
then what? Or it is
Yeah.
still embolus?
then depending on the level it is, if I can manage to suck it out with using a guiding catheter, then I would do it.
Yes.
If it is well below, in say beyond the mid calf, then to get a guiding catheter there is difficult. So then I may use one of your coronary aspiration catheters, like a
Export or
what do you call it?
thrombuster and
yeah.
export.
Or pronto, yeah, thrombuster, export, pronto, one of those catheters, and then try and suck out the thrombus.
So you need to have all
The
these
last
ready.
alternative is, in case you are going, yeah, last alternative is, in case you know it's a thrombus and not a plaque, then you can even start an infusion of urokinase or RTPA and get the patient back after 6 hours and see if the thrombus has lysed.
Great. So I think so. That's it. Any more questions that you
Just
want
one
to-
more question regarding
As far
the
as rupture is concerned, there was,
Yeah.
regarding the antiplatelets.
yeah, I
so
think there was a question about whether there is a rupture.
No, there's one more question, Girish, before rupture. I think you'll answer that first. Yeah, your question.
about the antiplatelets, so what's the length of the antiplatelets and what kind of combination? So he's using aspirin plus Plavix or other antiplatelets like Prasugrel or other new.
Yes.
No, I didn't get.
Girish, the antiplatelets.
I didn't get that question.
What is before the procedure
Yeah,
antiplatelets?
we are giving. We have given Ecosprin and Clopidogrel. We've started, in case you are not loaded the patient earlier with antiplatelets and you get the patient on table as an emergency, then we give 4 tablets of Clopidogrel on table and with Ecosprin, and then we start the procedure. Otherwise, as I said, 4 to 5 days before the procedure, we start the patient on 150 milligrams of Ecosprin and 75 milligrams. Sometimes when you are worried about thrombus, then we even start up to 150 milligrams of Clopidogrel.
So that's a protocol, yeah. And if there
You
is
have
a
the
rupture,
newer antiplatelets.
yeah, about
Rupture, that
you
is
were
one
answering.
thing which we know. And what happens is, usually if you keep a balloon across the ruptured segment for a span of about 5 minutes, these ruptures usually seal off. But unless you have really oversized your balloon, then you may have a total give of the artery, and then you have no alternative but to go in and embolize the artery. Surgical intervention at that point may be difficult, and then we are looking at a question of either looking at the circulation, whether we need to do a below knee amputation or not. But with the grace of the Lord up there, we've never had that problem. And one of the reasons why we haven't had that problem is we always undersize the balloon to a certain extent. So if the artery is say 3, we would go up to 2.5 and not dilate at very high pressures, even if I take a 3 mm balloon.
Okay. We have Dr. Abu Salem, who's a surgeon. And sir, what is your workup as far as or how do you look at a tibial bypass as a procedure in these kind of things vis-a-vis the interventions here?
I would look at the runoff. If I've got a very good runoff,
Yes.
then a bypass is much better, depending on what you're trying to salvage.
Right.
If it's gangrene, critical limb ischemia, then certainly the bypass is a much better option
Right.
in our hands. And if you look at the Basel trial, it would appear that the bypass long-term duration is far, far superior.
Right.
Where you're trying to just salvage an ulcer healing, I think tibial angioplasty plays a big role, and that's the route we follow.
Yes. Okay. So again, you know, for surgery, small vessels, long segments, vein should be available, good surgeon, and your artery, which is often calcified, is another challenge which my surgeons would definitely comment about. And therefore, it has come down that endovascular first is probably the way to treat these patients with diabetic foot, and that's why you see the technology advancement in this area. So great show, Girish, and great round of applause from the group here. A wonderful demonstration to the Ajay is there, our technologist. I'm sure Pradeep is there, and the nursing staff there.
Yeah.
I can see Asha there. Asha, come out of that screen.
Here is
there.
the sister here.
Dekho. Thank you very much, sisters, and good show there. Thank you again, and the audio video team there who's done a good job, and obviously my hospital, Raheja Hospital, which is famous for diabetes and diabetic foot. We have a lot of good work there. We have good vascular surgeons and good diabetic foot surgeons. Dr. Arun Bal is probably the father of diabetic foot in the country. We have Dr. Sanjay Vaidya, who gave us this case, and thanks again to the patient. So just tell him thank you, Girish.
Yeah,
Thanks to the patient for
And
allowing
Vimal,
us. Yes.
no, just one question to the Dr. Salem.
Yes.
What is their results of femtibial bypass?
So,
I think long-term patency with us, if you've got a good vessel running down the leg, is at least 5-year minimal patency rates we're achieving. With vein grafts, I'm not talking about prosthetics.
But unfortunately, I'm talking about autologous venous graft.
But as
But
I
we
said,
don't see those results here. I don't know why.
I think the problem is we get very late, certainly in our country, we get the patients coming in very late, and the distal vessel runoff is really bad.
yes.
So I think if you've got, I've got graft patencies in my own practice, 10 years still going with the vein graft. But again, it depends on the runoff and inflow. So there's multiple factors, but if you look at wound complications, they're much, much higher than we anticipate, especially with diabetics. The wound problems are a real problem. And certainly my practice has changed tremendously. I've done one distal bypass in the last year. Majority of my patients are getting angioplasty.
No.
And the advantage of the angioplasty is that you can go back in
Yes.
and redo them. If they narrow
Yes.
enough or you find that
Yes.
the ankle brachial index dropping, go back in, you'll get a good result and keep it long-term patencies.
Wonderful. So that's what the trend is, and
Okay.
thanks again, Girish, for everything. And
Okay. Thank you very much.
thanks again, Girish, very much.
Yeah.
I think we'll go ahead with the next lecture, and incidentally, that's me again. So I'm going to invite myself here. So if you don't mind, I'll continue. Please go ahead. Please. So, I'll have my slides up there. If it works out a little longer, I'll need the pointer for sure when I'm doing this. So there's a pointer which shows. Now, I'm going to talk to you about what's new